I'm Dr. John Kruse, and today I'm going to be talking about menopause and ADHD. And actually, the title is a misnomer because I'm going to be talking about menopause and ADHD symptoms rather than women who already have ADHD to begin with. So that highlights part of the take-home message. The take-home message is, as of the end of 2024, there are no formal studies of women with ADHD who've been studied before, during, and after menopause to see if there's a change in ADHD symptoms. This reflects our relative in medicine, the ignoring of women, the ignoring of menopause as an important event in life, and the minimization of studying women with ADHD. So all of these are converging. That doesn't mean we have no information at all. So there are a number of studies that indicate a subjective problems with concentration, attention, working memory are all disrupted for a sizable percentage of women during the perimenopausal period. And at least for some women, these are extending into the post-menopausal period. And there are preliminary studies showing that, again, these are women without ADHD to begin with who had ADHD symptoms evoked by menopause. And there are studies suggesting tentatively that hormonal treatment, Atomoxetine, Strattera, and Vyvanse, lisdexamfetamine may all help with cognitive functioning. So that's a take-home message. So jumping into the main talk. Menopause, what is that? So menopause is strange to study in one way in that it's defined usually as a cessation, the complete stoppage of all menstrual blood flow, menstrual activity for at least a year. And that means that we can't ever define it until it's retrospective, till it's already been completed and afterwards, in fact, at least a year afterwards. We know that on average in the US, the age of menopause is about 52. That means women are spending on average, a third of their life in a post-menopausal state. We know that the menopause itself is usually preceded by, on average, a 4-year, some would rate it longer, perimenopausal period. So during the perimenopausal period, there are fluctuating levels of estrogen and progesterone, periods of decreased and periods of increased. That leads to both lengthening and shortening of menstrual period, and of variability, not in just the length of the period, but in the amount of blood flow, again, leading to lengthening and less frequent menstrual periods. And in the post-menopausal period, estrogen levels and progesterone are substantially lower than they are during the woman's reproductive years of her life. So they're almost negligible. Perimenopausal period is characterized by symptoms what are called vasomotor, so affecting the peripheral vascular system and muscular system. So those include hot flashes, night sweats. Vaginal dryness is also a symptom. Other symptoms that are prominent during the perimenopausal period are moodiness and joint pain, associated with the perimenopausal and more, because these are longer going processes with postmenopause, menopause, are bone loss, increased abdominal fat, changes in cholesterol and probably fat and sugar metabolism. So there's an increased risk of strokes, blood clots due to vascular changes from menopause on, and changes in the risk of diabetes and heart attacks. So they're more closely approaching the rates in men after menopause. The most common medical intervention used to treat, so there's indication that stopping smoking, reducing alcohol, greater exercise, all the healthy lifestyle things can minimize some of the distress and some of the severity of some of these perimenopausal symptoms. SSRIs are often used to treat hot flashes. The official gynecological obstetrical organizations and hormonal endocrine associations indicate that the only clear-cut indication for menopausal hormonal replacement therapy is in the setting of someone who's at high risk or is already experiencing significant bone loss. That doesn't mean there may be many other individuals where it may be useful or helpful, but no generalized recommendations for other categories are present. And part of it is that treating women with hormonal replacement therapy, as it used to be called, menopausal hormonal therapy is more often the abbreviation now. So that usually includes some combination of estradiol and or, particularly if a woman has a uterus still, progesterone. That does somewhat increase risk of strokes and of blood clots. It increases the risk of certain gynecological cancers. Those risks seem to have been elevated in older studies. So for many healthy women, the increased risk, there do not seem to be many increased risks of MHT, of menopausal hormonal treatment, but consult with your doctor. Some of the things that make studying effects of menopause difficult is that this is happening at a time when people are leaving middle age and approaching late age, and there are cognitive changes happening there anyway. So separating out whether someone is experiencing or groups of people are experiencing changes because of menopause or just because they're getting older is difficult. And unless studies control for what the hormonal status or what the phase of the life the woman's in versus age, that can be confusing. There are probably also substantial differences between perimenopause and postmenopause. Again, in perimenopause, estrogen levels are fluctuating dramatically, as are progesterone, whereas in postmenopausal, they are pretty flat and extremely low to non-existent, certainly coming from the ovarian source. There are also cultural issues, so different cultures treat and address and suppress or encourage different menopausal, perimenopausal symptoms differently. Be that as it may, there are now numerous studies done in a variety of different cultures that indicate a majority of women during the perimenopausal period, again, when we're having fluctuations, have subjective memory complaints, concentration difficulties, and mood control difficulties that were not there preceding their perimenopause. It's less clear how many of these changes persist in the menopausal period, but at least for some women, a substantial number of those. The other thing to highlight is that this is not universally the case. So there have been a few studies looking at different patterns of cognitive and executive functions across the perimenopausal and to menopausal period. And while many women have some deficits, changes, problems early on, there are some women who do not experience any of that. And there are some women who seem to have particularly well-preserved executive functions during perimenopausal years. So why are hormonal symptoms that we usually think of as affecting the body, why are those having any impact on the brain? So one is there are estrogen receptors throughout the brain. There are certain areas that are particularly rich in estrogen receptors. Those include the amygdala, the hippocampus, the hypothalamus, the cerebellum, and probably most tied into ADHD symptoms, the prefrontal cortex. And we know that those estrogen receptors, so estrogen is thought more to be having a neuromodulatory role there, and that those estrogen receptors are modulating both dopamine. This is oversimplification, that in the prefrontal cortex, particularly increasing dopamine, which should be good for ADHD. So having less estrogen is bad. And estrogen also seems to dampen down glutamate, and too much glutamate also seems to exacerbate ADHD or associated with ADHD symptoms. So I'm going to jump into a few studies done by a group of researchers I will single out two of them. So Tom Brown, who was at Yale, now at Riverside in California. C. Neil Epper. So Tom Brown's a psychologist who's written extensively, particularly on executive functions and ADHD. C. Neil Epperson is a psychiatrist who was at University of Pennsylvania and is now in Colorado. And she and he, and they have several other collaborators, conducted several studies in the last decade. These were all looking at women who did not have a diagnosis of ADHD, did not have executive function deficits pre-perimenopause, but then experienced substantial differences during that perimenopausal period. And I'll go into this a little bit. Tool that they were using for most of these studies is the BADS, BADDS. That's a tool designed by Tom Brown. It's a self-report ADHD scale, but unlike almost all the other scales we have, which are 18 different points based on the 18 DSM criteria, the 9 inattentive, the 9 hyperactive, disinhibited symptoms on DSM, this uses 40 questions in 5 different domains that addresses a broader range of ADHD symptoms and has tried to get a more representative feel of what impairs people with ADHD. So the BADS is divided in the 5 domains are 1, organizing and activating oneself for work. 2, sustaining attention and concentration during tasks. 3, sustaining alertness, effort, and processing speed while performing tasks. 4, managing affective interference, which could be summarized as emotional regulation or control, so those don't interfere with tasks. And 5 is using working memory and accessing recall. So this in many ways tries to capture more of the problems and challenges that individuals with ADHD deal with. So in their first study, looking at atomoxetine, they recruited 16 women wound up in the study. This was a randomized placebo-controlled study. So for 6 weeks, the women were on either 80 milligrams of Strattera or placebo. Then they had a 2-week washout period. They didn't know what they were getting. The investigators didn't know. And then for another 6 weeks, they were on whatever they didn't have the first time. So it's a crossover design. And what they found was that the total BAD score decreased in the atomoxetine. Individuals were taking atomoxetine, but not all taking placebo. And specifically, the working memory subdomain of the, or domain of the BAD score also significantly improved. Score dropped during this treatment with atomoxetine. There was a trend for superiority, for improvement during atomoxetine with the attention concentration cluster, but it wasn't quite at the level of statistical significance. And on a few formal neuropsychological tests that were done, there weren't observable changes, and there also were not any changes in the cardiovascular monitoring. So an important point to make here is that in a number of studies, not just with menopause, but with the ADHD in general, the tests, whether they're based on the 18 DSM criteria or the BADS or other subjective descriptions of problems with attention, distractibility, impulse control, much more finely register differences in response to medications or severity of ADHD than do our formal neuropsychological testing. Part of it is that the tests themselves are so artificial that they're restricting distractions. They're sort of directing and guiding you to attend to what's going on, that even though they may be measuring some brain executive function, they're not very good, valid, real-life measures. So that group of investigators also did a couple studies with Vyvanse, lisdexamfetamine. So in their first study, they looked at 32 women, and this general design is similar, but it's a little different. So they had 4 weeks on Vyvanse, 2-week washout or placebo, then a 2-week washout period, then 4 weeks on the other treatment they hadn't received the first time. Blind to treatment were the individuals, the investigators were blind to treatment. The treatment consisted of first week, 20 milligrams of Vyvanse, second week, 40, third week, 60, if they could tolerate it. Almost all the, I think, 90% of the women tolerated the 60. A few were left at the lower doses, 1 or 2. Average age of the women was 53, and it was on average almost a little over 2 years since the last menstrual period. So this is in the early post-menopausal period. Only 3 women in the PULDA group had been on any hormonal replacement therapy during their perimenopausal years, and most not. And again, like the Atomoxetine study, this time with Vyvanse, there was a significant decrease in the BAD score. So I should have backed up and said, what's significant? One is these were women who were recruited because they had problems with concentration, memory, subjective, executive function complaints. But the severity of the complaints they were having matched the severity we see in full-blown ADHD from childhood scores. So these are not just minor complaints. These are at the level of impairment that we see in full-blown ADHD with this group in general. So with Vyvanse, there was a significant decrease in the overall BAD score, and for the domains organizing and activating, sustained attention concentration, sustained alertness processing speed, and the working memory recall significantly statistically improved. There was the 5th domain, the emotional regulation domain. That was the one least impaired to begin with in this group. And there was a trend towards improvement, but it wasn't statistically significant. Somewhat similar to the Atomoxetine, most of the other formal cognitive neuropsychological tests did not show any difference, with the exception of a delayed paragraph recall, where a paragraph with 20 details, pertinent details thrown in, and you're asked to recall them immediately and at a delayed period. So there was measurable improvement in that formal test. There were slight increases that were statistically significant in blood pressure and heart rate, but those probably were not clinically meaningful, and that they were less than 5 points with blood pressure. I think it was 2 beats per minute in heart rate, and the overall levels or scores on heart rate and blood pressure were certainly well within the normal range. So this Epperson-Brown group also did a study related to this overall Vyvanse study where they included brain imaging. This study only had 14 women, but same design. So crossover, 4 weeks on Vyvanse or 4 weeks placebo, and then switching over after a 2-week washout to the other group, not knowing what individuals were on. And in this brain imaging, there was increased activation in the insula and in the dorsolateral prefrontal cortex when individuals took Vyvanse, and there was a decrease in overall BAD score and all 5 domains in the BAD score, so all of them in this study. And there's a correlation between the degree of activation in insula and dorsolateral prefrontal cortex. So that correlated with how the more you activated these parts of the brain, the more your decrease in your BAD score. And they also measured glutamate levels in the dorsolateral prefrontal cortex. Those decreased, and again, the extent to which your glutamate decreased correlated well with your overall symptomatic improvement on the BAD score. Reminder, the insula is part of the singular opercular network that's critical for cognitive control, and particularly for error monitoring and making sure you're on track and doing well. So also in this test, none of the neuropsychological tests were formally improved or changed. There have been very few other groups doing studies like this. There's one somewhat similar study by a French group with Girard. They looked at hormone replacement therapy, so estrogen, progesterone combination in early postmenopausal women, and found increased prefrontal cortex activity in the women given hormone replacement therapy in areas that would be significant to executive functions. So the overall summary, things to be aware, is these are not individuals who had ADHD. There are studies that are going. There are certainly anecdotal and case reports written up that women with ADHD can have substantial worsening of symptoms in the perimenopausal years. But these, again, are women who did not have ADHD premenopausally, but had symptoms as severe as those reported by individuals with ADHD during their perimenopausal and postmenopausal years. Again, the scores on the BADS indicated substantial improvement with some of these interventions, but the formal neuropsych tests didn't show significant differences in most instances. And the other important things to be aware of with these studies is that, again, this was a sample of individuals women picked because they were having cognitive problems. That does not mean every woman during her perimenopausal, postmenopausal years is going to have such cognitive problems. Also, these studies overrepresented white women and women who were well educated. Substantial majorities had 4 years of college, and high numbers had graduate studies as well. Again, we know there are cultural and other factors and correlates with general health that may make this an unrepresentative sample. There are studies that are ongoing looking at women who have ADHD to begin with and looking at the impact of menopause on them. But right now we don't have them. It would not be surprising if women who already were having problems with some of their executive functioning, emotional regulation, attention control would have worsening. But again, we don't have a lot of formal studies. The work here would suggest that many of the treatments, medication treatments that seem to help with ADHD symptoms in the setting of menopause. So that's about all I have to say today. If you have comments, you can write it here on the YouTube channel, and I'll be doing my weekly Tuesday question and answer session this week and every week for the near term. So stay healthy, stay happy, and so long.